You know, there is a phrase that gets thrown around in medicine all the time, specifically when people talk about treating kids. It's almost a cliche at this point. Children are not just little adults.
It is a cliche, and I think it's a cliche because we have to keep reminding ourselves of it. The instinct is so strong. You see a sick child, and your brain just defaults to engineering. You think, okay, take the adult protocol, cut the dosage in half, use a smaller needle, and we're good to go.
Right. It feels like a scaling problem, like you're just dealing with a smaller version of the same machine.
But that is a biological fallacy, and honestly, it's a dangerous one. If you walk into this deep dive thinking a child is just a miniature grown-up, you are going to miss the mechanism of almost every single disease we discussed today.
Because it's a different operating system entirely.
It is, because adult medicine is largely about maintenance. It's about keeping the machine running, patching leaks, clearing clogs. Pediatric medicine, and specifically pediatric pathology, is about construction.
Right. We aren't fixing a leaky pipe in a house that's been standing for 40 years. We're trying to fix the foundation while the concrete is still wet and the walls are literally going up around us.
Exactly. And that is the central tension of today's entire discussion. The very processes that build a human being, rapid cell division, cell migration, complex organ folding, those are the exact same processes that create unique windows of vulnerability, windows that simply don't exist for you or me anymore.
So today, we are doing a proper deep dive into the diseases of infancy and childhood. And we've got a heavy stack of sources for this one. We are synthesizing two of the absolute heavyweights of medical literature.
We're using Robbins' and Tatran pathologic basis of disease, specifically the chapter on this topic, which gives us that massive unifying systems framework. And we're pairing it with Underwood's pathology, which is just brilliant at explaining the mechanism, the nuts and bolts of how injury happens and how tissues respond.
Now, before we get into the heavy stuff, and there is some heavy stuff here, we need to drop a very specific disclaimer.
Right. This conversation is an interpretive synthesis. We are building a conceptual map here. If you are a medical student or a resident listening to this before your boards, please do not skip the textbooks.
Yes, please don't.
You need to see the histology slides. You need to read the fine print on the protocols. We are here to help you understand the logic of the pathology, not replace the curriculum. Reading the original chapters remains absolutely essential.
The goal is to give you the framework so that when you do read the book, it all clicks into place. It sticks. So looking at the outline, our mission is to explain why disease happens in kids, not just list a bunch of syndromes. And we should probably start by signposting the key takeaways.
Let's do that. If you only remember 5 things from this hour, here is what they should be. Number 1. Childhood disease reflects the developmental stage, not just body size.
The construction phase.
The construction phase. Number 2. The timing of an injury determines the pattern and severity of the pathology. The when matters more than the what.
That's a huge one.
It's massive. Number 3. Congenital anomalies usually stem from disrupted morphogenesis, the architecture of building the body. Number 4. Inborn errors of metabolism reveal how single biochemical blocks can derail incredibly complex systems. And number 5, and this is my favorite, developing tissues possess a duality. They have extreme vulnerability, but also remarkable resilience or plasticity.
I love that last point. Vulnerable but resilient. Okay, let's unpack this. We have to start at the beginning. Section 1, the logic of morphogenesis, or, as you put it, building the machine.
Right, and Underwood defines morphogenesis as the complex process of developing shape and form.
I think most lay people hear growth or development and just think of, multiplication. You start with one cell, you end up with trillions. It's just getting bigger.
That's the intuition, absolutely. But Underwood points out something that feels really counterintuitive. Morphogenesis isn't just about generation, it is equally about destruction.
Destruction in the embryo, that sounds wrong.
It's essential destruction, programmed cell death, apoptosis.
We usually think of cell death as a bad thing. Necrosis, injury, rot.
That's pathologic death. That's unplanned, messy death from injury. But in the embryo, death is a sculptor. Think about your hand. In the very early embryo, your hand is essentially a paddle. It's a solid, joyful of tissue. There are no fingers.
A solid mitten of cells.
A solid mitten, exactly. To get fingers, you don't grow them out from the paddle. You have to carve them out of the paddle.
So the cells between where the fingers will be, they have to die.
They have to commit suicide. They undergo apoptosis. The signaling pathways tell them, your job is done. Make space. If they fail to die, if that death signal is missed, You get syndactyly.
Webbed fingers.
Webbed fingers. The tissue is still there because the death failed.
That is a wild image. The empty space between my fingers is created by a cellular massacre.
It is, and it happens everywhere. Your gut starts as a solid cord of cells. It's not a tube.
Yeah, really, it's solid.
Completely solid. To become a tube that can digest food, the cells in the center of the cord have to die and clear out. That's a process called recanalization. If they don't die, you get something called atresia, a blockage, a solid gut. It's incompatible with life outside the womb.
So rule number 1 of construction, death creates function. Now, obviously, this complex dance of growing and dying can go wrong. Robbins categorizes these errors into 3 really distinct buckets: malformations, disruptions, and deformations. And I want to spend a minute here because I think most people use these terms interchangeably, but they are not synonyms in pathology, are they?
No, and the distinction is absolutely vital, not just for exams, but for counseling pairs. The difference tells you the cause, and more importantly, it tells you the risk of it happening again to a future child.
Okay, let's break it down. Let's start with the first bucket, malformations.
Think of a malformation as a blueprint error. This is an intrinsic error in the developmental process itself. From the very start, the instructions were wrong. This is usually genetic, chromosomal defect like trisomy 21 or a single gene mutation. The plan for the heart, or the lip, or the kidney was drawn incorrectly from day one.
So a cleft lip, that's a classic example.
Usually a malformation, yes. The tissues that were supposed to fuse in the midline simply didn't because the genetic signaling was off. Polydactyly extra fingers is another one. The blueprint said make 6, so the body made 6. It's following faulty instructions.
Okay, so that's the blueprint. Contrast that with bucket number 2, disruptions.
A disruption is a wrecking ball. Imagine you have a perfect blueprint, the construction crew is doing a great job, the organ is forming perfectly, and then bam, an extrinsic disturbance comes in from the outside and destroys it.
So the genetics are normal.
Perfectly normal. The blueprint is fine. The classic tragic example here is amniotic bands.
I read about this. It's the stuff of nightmares.
It is visceral. The amnion is the inner sac holding the fluid and the baby. Sometimes it can rupture or tear. When it does, it forms these sticky, fibrous strands that float in the amniotic fluid. As the baby moves and kicks, a limb, an arm, a finger, a leg can get tangled in one of these bands.
Oh, like a tourniquet.
Exactly like a tourniquet. And as the baby grows, the band doesn't. It constricts. It cuts off the blood supply. It can literally amputate a hand or a foot in utero. The baby is born with a missing part, not because it failed to form, but because it was destroyed after it formed.
But here's the key question for the parents. If I have a child with an amputated hand due to amniotic bands, what are the odds my next child has it?
Extremely low. Virtually zero. It's a mechanical accident. It's not in your DNA. It's like lightning striking. Compare that to a malformation, like a cleft lip, which might have a 5% to 10% recurrence risk because it's tied to the family's genetics. You see why the distinction matters so much.
It's a huge difference. A world of difference in counseling.
Okay.
Bucket number 3, deformations.
Deformations are about space, biomechanics. The problem isn't the blueprint or a wrecking ball, it's the construction site. Imagine you are growing a pumpkin inside a square glass box. The pumpkin is genetically normal. It wants to be round. But as it grows, it hits the walls. It becomes square.
It's molded by the container.
Exactly. This usually happens later in pregnancy, say weeks 35 to 38. The fetus is growing really rapidly, but the uterus isn't keeping up. If the uterus is too small, maybe it's a first pregnancy and the muscles are tight, or maybe there are twins crowding each other, or there's low amniotic fluid, the fetus gets compressed.
And the result is something like club feet.
Talipes equinovarus, yes, that's the classic one. The foot is twisted inward, not because the bone formed wrong, which would be a malformation, or because a band cut it, which would be a disruption, but because it was squashed against the uterine wall for 4 weeks.
And the good news with deformations.
They're usually reversible. Because the genetics are fine, the blueprint is normal. If you relieve the pressure after birth, you use splints, casts, physical therapy, the tissue responds, it wants to be normal, it springs back into shape.
That's a really helpful framework. Blueprint for malformation, wrecking ball for disruption, and tight box for deformation.
It's the pathologist's triage. It helps you think through the cause.
This brings us to a concept that I found really, really helpful in the reading, the sequence. Because sometimes one thing going wrong triggers a whole domino effect. Robbins calls this the Potter sequence.
The Potter sequence is the textbook definition of a sequence. It's a detective story where you have all these clues at the end and you have to trace them back to the single initial crime.
Walk us through the dominoes. How does it start?
Okay, so the trigger event is usually something affecting the kidneys. Let's say renal agenesis, the kidneys fail to form completely.
That sounds bad enough on its own.
It is, but think about the function of fetal kidneys. What do? They make urine. And what is amniotic fluid, mostly?
Fetal urine.
Mostly, yes. It's a brilliant system. It cycles. The fetus swallows fluid, pees it out, swallows it again. This process is essential for maintaining the volume of the amniotic sac, which acts as a cushion. So no kidneys means no urine. No urine means no amniotic fluid. That's a condition called oligohydramnios.
Okay, so now the pumpkin is in a box with no cushioning, the tight box scenario.
Exactly. The fluid cushion is gone. The uterus collapses around the fetus. This causes the deformations we just talked about, a flattened face, what we call Potter facies, clubbed feet, dislocated hips, all from compression.
But Robin says the lethal consequence isn't the kidneys or the club feet, it's the lungs.
This is the critical connection, and it's what makes the sequence fatal. For lungs to develop properly, two things have to happen. The fetus needs to breathe amniotic fluid, inhale, and exhale it to stretch the lung tissue. And the chest wall needs room to expand. In the Potter sequence, both are gone. There's no fluid to breathe, and the chest is compressed. The lungs can't grow. You get pulmonary hypoplasia.
So the baby is born, and even if you could theoretically fix the kidneys with a transplant or dialysis.
It doesn't matter. They can't breathe. The lungs are just too small to support life. It's a fatal sequence of events starting from one single error, the missing kidneys leading to a cascade of pathology.
That really illustrates the system nature of this. You can't just look at one organ in isolation.
Never. In development, everything connects to everything else.
This leads us perfectly into section 2, the critical element of timing. You mentioned earlier that the when matters more than the what. Robbins breaks prenatal development into two big phases, the embryonic and the fetal.
Right. And the stakes, the types of damage you can do, are completely different in each phase.
Let's start with the embryonic period, which is the first 9 weeks.
Right.
Robbins calls the very first 3 weeks the all or none period.
Oh.
That sounds intense.
It's binary. It's life or death. In those first 0 to 3 weeks, the cells are tutipotent. They haven't really decided what to be yet. They're like ultimate stem cells. If a teratogen, an insult like a drug or radiation, hits now, one of two things happens. Either it damages so many cells that the embryo is not viable and spontaneously aborts, often before the woman even knows she's pregnant, or it damages only a few cells. The remaining cells are so plastic, so adaptable, they just fill in the gaps. They compensate, they divide, they recover completely, and the fetus develops with no defects.
So it's survival with no defects or death, all or none.
Exactly. But then we hit week 3 to week 9. This is organogenesis,
The danger zone.
the absolute peak of vulnerability. This is when the organs are being crafted. The heart is folding from a simple tube into a 4-chambered pump. The neural tube is closing. The palate is fusing. This is where teratogens cause specific, permanent structural malformations.
And different organs have different windows within that period, right?
Yeah. Yes, very specific timetables. The neural tube closes very early, around week 4. So if you have a severe folate deficiency in week 4, you can get spina bifida. But if you have that same folate deficiency in week 20, the neural tube is already closed and sealed. You've missed the window for that specific defect. It might cause other problems, but not spina bifida.
Then we move to the fetal period, from 9 weeks all the way to birth. Organogenesis is mostly done.
The blueprint is drawn, the walls are up. Now it's about growth and maturation. Wiring the brain, growing the lungs, putting on fat. So teratogens here are less likely to cause a structural hole in the heart, for example, but they are very likely to cause growth restriction or damage to the brain, which is still developing at a furious pace.
Speaking of teratogens, Robbins has this fascinating section on how environmental toxins, these teratogens, often hijack the body's own genetic signaling pathways.
This is such a profound insight. We used to think of toxins as just poisons that killed cells indiscriminately, but now we know they're often much more subtle. They are mimics, they pretend to be biological signals and give the wrong instructions.
The example that just blew my mind was the cyclops sheep.
Ah, yes. Cyclopamine, the story is incredible.
It sounds like a made-up comic book villain chemical.
It's real. It's a chemical found in the corn lily plant in the western U.S. For years, ranchers would find that in certain seasons, their pregnant ewes would give birth to lambs with these horrific defects. They could have holoprosencephaly, the brain fails to divide into 2 hemispheres, and most shockingly, cyclopia, one single fused eye in the middle of the forehead.
And Robbins says this happens because cyclopamine, the chemical in the plant, inhibits the hedgehog signaling pathway.
Exactly. The sonic hedgehog pathway, to be precise, is a crucial genetic pathway that tells the developing face and brain, hey, split down the middle. Make two eyes, not one. Make two brain lobes. Cyclopamine blocks that signal, so it perfectly mimics a genetic mutation in the hedgehog gene, but it's an environmental toxin.
That is just wild. And there's a human pharmaceutical example too, isn't there? Valproic acid. It's an anti-seizure medication.
Right. Valproic acid is known to disrupt HOX proteins. HOX proteins are like the master architects of the body plan. They line up along the embryo and tell the limbs where to bud, the vertebrae how to stack up in order. If a pregnant woman takes valproic acid at the wrong time, it messes with those HOX proteins. The baby can be born with limb and spinal defects that look exactly like what you'd see in a child with a genetic HOX mutation.
It really blurs the line between genetic and environmental, doesn't it? It's like they're playing on the same piano keys.
That's a beautiful way to put it. The keys are the signaling pathways. Whether a genetic mutation hits the key or a chemical toxin hits the key, the discordant note, the malformation, is the same.
We can't talk about environmental factors without mentioning vitamin A.
Right.
Because I think most people, myself included, just assume vitamins equals good. More is better.
A very dangerous assumption in pregnancy. Not with vitamin A or retinol.
Why? What does it do?
Vitamin A is a potent regulator of gene expression. It's not just a cofactor. It directly tells genes to turn on or off. It specifically regulates the TGF-beta pathway, which is heavily involved in palate formation. If you have a deficiency, that's bad. But if you have an excess, say, from taking high-dose supplements or using certain retinoid acne creams like Accutane, it is catastrophic. It completely dysregulates that signaling. You can get severe cleft lips, palate defects, and major heart anomalies.
So it's a Goldilocks principle. Not too little, not too much. Just right.
Exactly. Development is all about balance.
Let's touch on one more maternal factor before we move on. Diabetes.
Maternal diabetes is a massive issue. We'll talk about how it affects lungs later, but in early pregnancy. The high blood sugar itself is a teratogen. It generates reactive oxygen species, free radicals that damage the developing tissues. If that happens during organogenesis, you can get severe cardiac defects and neural tube defects. But later in pregnancy, it leads to a different problem: macrosomia.
The big baby.
The very big baby. The mother's high sugar crosses the placenta. The fetus responds by pumping out tons of its own insulin. And insulin isn't just for sugar, it's a powerful growth factor. So the baby gets huge, the organs get huge, the heart, the liver. It causes all sorts of mechanical problems at birth, and the baby is at high risk for hypoglycemia right after birth when the maternal sugar supply is cut off.
Okay, moving on to section 3. We were leaving the womb maybe a little too early. Prematurity.
Prematurity is the second most common cause of neonatal mortality right after congenital anomalies. And here we need to distinguish between being premature and being small for gestational age, or SGA.
They aren't the same thing.
No, and it's an important distinction. Premature is strictly about time. Born before 37 completed weeks of gestation. You could be a premature baby who is actually perfectly sized or even large for your age. SGA means you are smaller than you should be for your age, regardless of when you were born. That implies fetal growth restriction, or FGR, something was starving you or stressing you in the womb.
But let's focus on the premature infant. The organs are there, but they just aren't ready for prime time. The classic issue is the lungs. Neonatal respiratory distress syndrome, or NRDS.
This brings us right back to building the machine. The lungs are structurally formed, but they are functionally incompetent. Why? Because they lack a magical substance called surfactant.
Surfactant. It's like a detergent, right? It breaks surface tension.
Essentially, yes. Think of the alveoli, the tiny air sacs in your lungs, as millions of tiny wet balloons. You know how hard it is to blow up a brand new balloon for the first time? The walls stick together.
Right, it takes a huge effort.
That's surface tension. Surfactant, which is made by cells called type 2 pneumonocytes, coats the inside of the alveoli and reduces that surface tension. It makes the balloon easy to inflate. Without it, every time the baby exhales, the balloons collapse completely. They stick shut. The baby has to work incredibly hard with the strength of that first-time inflation to reopen them with every single breath.
That sounds exhausting.
It is fatal exhaustion. The baby develops progressive atelectasis lung collapse and essentially suffocates because their lungs just can't stay open. And when you look at these lungs under a microscope, and this is a key image for any medical student listening, you see hyaline membranes.
Hyaline membranes, that's the hallmark, the thing you have to know.
It's the buzzword, yes.
Yeah.
The tremendous effort of trying to breathe damages the delicate lining of the lungs. Plasma proteins like fibrin leak out and mix with dead cells to form this glassy, pink, waxy rind, the hyaline membrane. It coats the inside of the alveoli.
Which acts like a barrier, right?
Yeah.
So even if they get air in, the oxygen can't get through that membrane into the blood.
Exactly. It blocks gas exchange. It's a vicious cycle of injury and worsening respiratory failure.
Robbins mentioned some risk factors that surprised me. Obviously, prematurity is number one,
Right.
but also being male and maternal diabetes again.
The wimpy white male syndrome, as it used to be colloquially and unfortunately called in the NICU. But yes, androgens, male hormones, seem to delay lung maturation. And insulin from maternal diabetes. Insulin is a growth factor, but it actively suppresses surfactant production. So if the mom is diabetic, the fetus has high insulin, and surfactant synthesis is delayed, putting them at risk even if they're full term.
And C-sections, too. That's interesting.
Yes. The stress of a vaginal delivery is actually good for the lungs. The physical stress of labor releases a surge of cortisol, or steroids, from the fetus. And that cortisol surge is a powerful signal to mature the lungs and pump out surfactant. If you bypass labor with a scheduled C-section, the baby misses that beneficial steroid boost.
So we treat this with, well, giving them surfactant and oxygen, right?
We do, but oxygen is a classic double-edged sword. And this is a huge theme in pediatric pathology. The cure can cause the complication.
Robbins talks about retinopathy of prematurity. Is this related to the oxygen?
Directly. It's a disease we created with our treatment. When you put a premature baby on high levels of oxygen, their body, specifically the developing retina, thinks, oh, I have plenty of oxygen. I don't need to build any more blood vessels to the retina. So it stops producing VEGF, vascular endothelial growth factor. The vessel growth is suppressed.
Okay. That doesn't sound so bad yet.
But then the baby's lungs get better, and you take them off the high-flow oxygen. Suddenly, the retina is relatively hypoxic. It panics. It releases a massive, uncontrolled surge of VEGF. This causes a chaotic, disorganized overgrowth of abnormal blood vessels in the eye. These vessels are fragile, they leak, they scar and contract, and they can pull the retina right off the back of the eye.
Causing blindness.
Yes. It's what blinded musicians like Stevie Wonder. It's a direct consequence of the oxygen therapy that saved their lives.
Wow. And then there's the gut issue, necrotizing enterocolitis, or NEC.
NEC is the perfect storm in the NICU. It's a devastating disease. You need 3 ingredients. 1, a premature gut, which has a weak immune barrier and poor motility. 2, bacterial colonization, which is inevitable once you're born. And 3, oral feeding.
Why the feeding? Isn't that what they need?
It is, but in this context, the formula or even breast milk provides the substrate for the bacteria to go wild. The bacteria invade the weakened gut wall. They start fermenting the food inside the wall of the intestine.
Producing gas inside the bowel wall.
Yes, that's the pathognomonic sign on an X-ray. Pneumatosis intestinalis. You see little bubbles of gas inside the bowel wall. It causes massive inflammation, necrosis, or death of the tissue. The gut can perforate, spilling stool into the abdomen, leading to peritonitis, sepsis, and shock. It's a surgical emergency with high mortality.
It's terrifying how fragile these systems are. The lungs, the eyes, the gut, they are all teetering on this very fine edge of maturity.
That is the definition of neonatal intensive care. Managing that fragility, trying not to tip the balance.
Let's shift gears to section 4. We are moving from these big structural problems to chemical ones, genetic and metabolic errors. Robbins calls these inborn errors of metabolism.
A term coined by Archibald Garrod way back in 1908. He was a genius. I like to think of these as typographical errors in the body's instruction manual for biochemistry. Usually it's a single enzyme that is missing or broken.
And the mechanism is usually pretty simple, right? It's a broken step in an assembly line. So you either have too much of a toxic thing before the break or too little of a necessary thing after the break.
Precisely. It's a traffic jam. Let's take phenylketonuria, or PKU. This is the prototype.
This is the one they screen every single baby for in developed countries with the heel prick test.
Correct. And for good reason. The defect is in an enzyme called phenylalanine hydroxylase, or PAH. Its only job is to turn phenylalanine, an amino acid you get from eating protein, into tyrosine, another amino acid.
So if the enzyme is broken, phenylalanine piles up.
It piles up, and high levels of phenylalanine are severely neurotoxic. It poisons the developing brain. If you don't catch it, the child develops severe, irreversible intellectual disability, seizures, and microcephaly.
And because you aren't making tyrosine, what's the consequence of that?
2 things. Tyrosine is a precursor for melanin, the pigment in your skin and hair. So these kids are often very fair-skinned with blonde hair and blue eyes. Even in families with a much darker complexion, they have hypopigmentation. They also have a characteristic musty or mousy odor because the body tries to get rid of the excess phenylalanine through other shunt pathways, making these smelly byproducts in their sweat and urine.
But the timing aspect here is fascinating. The baby is born completely normal.
Yes. Why? Because the mother's liver and her normal PAH enzyme were doing all the work during pregnancy. The placenta cleared the toxins from the baby's blood. The baby is born clean. The damage only starts when the baby starts eating protein, either breast milk or formula, which contains phenylalanine.
That's why the screening is so vital. You have this brief window of a few weeks to intervene before the brain damage starts.
And the intervention is simple, but lifelong. Dietary restriction.
Yeah.
A diet with no phenylalanine. You give them a special formula. It's incredibly effective if you start early.
But there is a cruel twist in Robbins about maternal PKU.
This is a tragedy of our own success. We treated a generation of girls with PKU effectively. They grew up, went to college, had normal intelligence, were perfectly healthy. Many of them stopped the very restrictive diet as adults because their brains were fully formed and less vulnerable.
Okay, that makes sense.
But then they got pregnant. Now they have very high levels of phenylalanine in their blood. It crosses the placenta.
And acts as a teratogen on the developing fetus.
Exactly. Even if the fetus does not have PKU genetically, even if it's just a carrier, the mother's high phenylalanine levels act as a powerful teratogen, frying the baby's brain and heart in utero. The baby is born with microcephaly and congenital heart defects.
So a woman with PKU has to go back on that incredibly strict diet before she even conceives.
Absolutely essential. It's a critical piece of counseling.
Let's take galactosemia. Similar concept.
Very similar. A missing enzyme, GLLT, creates a biochemical traffic jam. Galactose, which comes from lactose in milk sugar, can't be processed. A toxic intermediate, galactose 1-phosphate, accumulates.
And where does that hit? What organs are damaged?
It's a multi-system disease. It hits the liver, causing jaundice and eventually cirrhosis. It hits the lens of the eye, causing cataracts. And it also damages the brain.
Robbins mentions a weirdly specific infection risk with this one that's a classic exam question.
Yes, E. coli sepsis. We don't fully understand the mechanism, but for some reason, the excess galactose seems to inhibit the function of neutrophils, our main bacteria fighting white blood cells. So if you see a neonate with jaundice, cataracts, and E. coli sepsis, you have to think galactosemia.
Got it. Now the big one. Cystic fibrosis or CF?
The most common lethal genetic disease in Caucasian populations. About 1 in 25 people of Northern European descent is a carrier.
This is the CFTR gene.
Right. It codes for the cystic fibrosis transmembrane conductance regulator, which is a fancy way of saying it's a chloride channel. It sits on the surface of epithelial cells in your lungs, pancreas, sweat glands, and its job is to pump chloride ions out of the cell. Water follows salt. So this process keeps secretions hydrated and thin.
If the pump is broken.
No chloride moves. Therefore, no sodium moves with it, and no water follows. The mucus on the surface of these cells becomes incredibly dehydrated. It turns from a thin, watery liquid into a thick, viscous glue.
And this glue blocks everything.
Everything. In the lungs, it blocks the small airways. It's impossible to clear. Bacteria, specifically Pseudomonas aeruginosa and Burkholderia, get trapped in that mucus and set up chronic infections, leading to inflammation and eventual lung destruction.
And in the pancreas.
The same thing. The thick mucus plugs the pancreatic ducts. The digestive enzymes can't get out into the intestine. The backed up enzymes cause inflammation, and essentially the pancreas digests itself, leading to atrophy and fibrosis. The child can't absorb fat, so they have malabsorption and fatty, foul-smelling stools called statorrhea.
And the sweat glands. That's the classic diagnostic clue, isn't it?
That's the basis for the sweat test. In the sweat glands, the CFTR channel's job is the opposite. It's supposed to reabsorb salt from the sweat before it reaches the skin. If it fails, the salt stays in the sweat, hence the salty baby. Mothers used to report that their babies tasted salty when they kissed them, long before we knew the mechanism.
Robbins talks about the genotype-phenotype correlation here. Not all CF is the same.
Right. There are hundreds of different mutations. It's not just on or off. The most common mutation, delta F508, is a processing defect. The protein gets made, but it's misfolded and destroyed before it ever reaches the cell surface. That's severe classic CF. But other mutations might just make the channel a little bit slow or not open as often. Those patients can have much milder disease, maybe just some recurrent sinus issues or male infertility from absent vas deferens, without the devastating lung destruction.
It's a spectrum.
Always a spectrum in genetics.
Okay, section 5, tumors of childhood. This is a heavy topic, but the biology is completely distinct from adults.
Completely different world. Adult cancers are usually carcinomatous cancers of epithelial cells. They're caused by years of wear and tear, sun exposure on the skin, smoking in the lungs, aging DNA, making mistakes.
But kids haven't been around long enough for that kind of wear and tear.
Exactly. Childhood cancers are developmental accidents. They are usually primitive tumors of mesenchymal, hematopoietic, or neural tissue. They look like embryological tissue that forgot to grow up or got stuck in a developmental stage.
And visually, under the microscope, they describe them as small, round, blue cells.
That's the classic description. If you look at a slide of adult lung cancer, you see cells trying to form glands or sheets of squamous cells. If you look at a common childhood tumor-like neuroblastoma or a Ewing sarcoma, you often just see sheets and sheets of tiny dark blue dots. They are undifferentiated. They are stem cell-like.
Let's talk about neuroblastoma.
This is a tumor that arises from the neural crest, the same migratory cells that make the sympathetic nervous system, specifically the adrenal medulla.
The weirdest thing about this tumor is its behavior. It can just go away.
It can. It creates a huge dilemma for oncologists. Neuroblastoma is famous for two things: being incredibly aggressive and for spontaneous regression. Sometimes the tumor cells suddenly wake up, realize they are supposed to be nerve cells, and differentiate into a completely benign growth called a ganglioneuroma.
And there is this specific stage 4S.
The S stands for special. This is seen in infants, usually under 1 year old. The child has metastases to the liver, skin, and bone marrow. In an adult, metastatic cancer is essentially a death sentence.
Right.
In stage 4S neuroblastoma, if the child is under 18 months and has favorable genetics, these widespread tumors can spontaneously regress without any treatment at all. They just melt away.
That is mind-blowing. The body just fixes the error.
Sometimes, but not always. The destiny of the tumor is often written in its genetics. If the tumor has an amplification of the MYCN gene, it is almost always aggressive and deadly, regardless of age.
Is there a diagnostic clue for neuroblastoma?
Yes, elevated catecholamines like VMA and HbA in the urine. Since it's a tumor of the sympathetic nervous system, it often secretes adrenaline-like substances.
Then there's Wilms tumor, kidney cancer in children.
Nephroblastoma, again, it's a tumor that mimics the embryonic kidney. It is thought to be derived from nephrogenic rests, little pockets of primitive kidney tissue that didn't finish differentiating and just lingered.
And this one is linked to the WT1 gene. But what caught my eye in the reading were the syndromes associated with it, the clues that a child might be at risk.
Yes. Wilms tumor likes to travel in packs with other developmental anomalies. If you see a child with aniridia, which is a missing iris, genital anomalies, and intellectual disability or retardation, that's Wagner syndrome, you better screen their kidneys for Wilms tumor.
Or Beckwith-Wiedemann syndrome.
The overgrowth syndrome. These kids are big. They have macroglossia, a huge tongue. They have huge organs, a condition called organomegaly. They have adrenal cytomegaly. They are at a hugely increased risk for developing Wilms tumor and other tumors like hepatoblastoma.
Section 6, the most difficult topic, I think, for anyone, SAID, sudden infant death syndrome.
It is the diagnosis of exclusion. It is a heartbreaking diagnosis. It means we have done a complete post-mortem examination. We have examined the death scene. We have reviewed the clinical history, and we still don't know why this infant died.
But we have theories. The triple risk model.
The triple risk model is the best framework we have. It helps us understand the complexity. It suggests you need 3 things to align for SID's death to occur. Number 1, a vulnerable infant. This could be a subtle underlying brainstem abnormality, perhaps in the serotonergic signaling pathways that control arousal from sleep. Prematurity is also a risk factor here. Number 2, a critical developmental period. The peak incidence is between 1 and 6 months of age. This is a time when the brain is taking over breathing control from more primitive reflexes. It's a period of instability. And number 3, an exogenous stressor. This is the environmental factor. The classic one is prone sleeping on the stomach. Others include soft bedding that can cause rebreathing of carbon dioxide or overheating.
So it's a perfect storm. The baby gets into a position where they can't breathe well, like face down on a soft mattress, the stressor. But because of the underlying brainstem issue, the vulnerability and being in that critical developmental phase, they don't have the normal arousal response. They don't wake up to turn their head and correct the problem.
Exactly. It's a disorder of arousal in response to a life-threatening challenge, and the success of the Back to Sleep campaign, which dramatically reduced SIDS rates, proves how important that exogenous stressor piece is.
So we have covered a massive amount of ground, from webbed fingers to missing kidneys, from toxic vitamins to disappearing tumors. What is the grand synthesis here? What does this all mean when you put it together?
If we zoom out, the biggest takeaway is that pathology in childhood is fundamentally different from pathology in adults. In adults, disease is often about accumulation, accumulating plaque in your arteries, accumulating mutations from smoking, accumulating damage from alcohol. In children, pathology is about interruption. It is normal physiology being interrupted, or normal physiology happening at the wrong time or in the wrong place.
Like the heterotopia idea tissue showing up in the wrong spot.
Exactly. Or the hyaline membranes in NRDS, that's just lung tissue that isn't ready for air yet. It's not diseased in the adult sense, it's just immature. The pathology is a mismatch between the developmental stage and the environment.
And there is this duality we mentioned at the start, the duality of vulnerability and plasticity.
Yes, the developing child is incredibly vulnerable. A single molecule of retinoic acid at the wrong time can rewire their face. A few weeks of compression can change the shape of their feet, but they're also incredibly plastic, incredibly resilient. A child can have half their brain removed in a hemispherectomy for severe epilepsy and go on to relearn to walk and talk. An adult could never, ever do that. The remaining brain rewires itself in a way that is just impossible later in life.
So I want to leave our listeners with a final provocative thought that came up in the reading. The idea of fetal origins of adult disease.
Oh, this is a huge and growing field. David Barker's hypothesis. We used to think, okay, you survived childhood, you're good, the slate is clean. But now we are realizing that the environment in the womb sets the thermostat for your health for your entire life. For example, if you had intrauterine growth restriction, if you were starved in the womb, your body makes choices. It prioritizes the brain over the kidneys. So you might be born with fewer nephrons, the filtering units in your kidney. You were born looking healthy. But 50 years later, you run out of renal reserve much earlier than someone else and develop hypertension or kidney failure.
So the high blood pressure a 50-year-old man has might actually be the result of his mother's placenta functioning poorly 5 decades ago.
Exactly. Or type 2 diabetes being linked to low birth weight. The fetus is the architect of the adult. We are all living in the house our fetal self built, with all its strengths and all its hidden weaknesses.
That is a profound thought, and a little terrifying.
It underscores the immense importance of prenatal health and maternal health. It's not just about having a healthy baby, it's about programming a healthy lifespan.
Well, on that note, we're going to wrap up this deep dive. To our listeners, this was a lot. Go read the Robbins chapter on diseases of infancy and childhood. Look at the pictures of the hyaline membranes. Look at the small round blue cells. It makes it real.
And read the Underwood chapter on growth and development for the mechanics of apoptosis and morphogenesis. It's truly fascinating stuff. This podcast supports effective reading. It does not replace it.
As always, stay curious, and we will catch you on the next deep dive.